third speaker, Dr. Hitendra Mahajan, who will be talking on making an impossible spinal possible.
Respected chairpersons, my teachers and dear friends, it is indeed a pleasure to be here in Pune because Pune gives me nostalgic feeling. I spent beautiful 12 years of my life in Pune, and to share my experiences, especially in front of my teachers, I thanks organizers for this opportunity. Dear friends, spinal anesthesia is something which is most commonly used by all of us, right from our residency days. But no one will deny the fact that once in a year at least we face a situation where leave apart injecting the drug in CSF, even dural puncture becomes difficult. And here lies our today's interest. I am not going to tell you something which is very difficult or very different, but then what we can do in this situation using available resources. And using this you can convert yourself from impossible situation to I am possible. Although spinal anesthesia is generally regarded as one of the most reliable types of regional block, the possibility of failure is there, ranging from 1 to 17% depending upon the experience. The reasons are innumerable. You can classify them as a dural puncture and related with subarachnoid injections. But then, difficulty in lumbar puncture is the only which is most obvious cause, and it is immediately obvious because you are not able to get the CSF. That may be because of abnormalities of spine like kyphosis, scoliosis, calcification of ligaments, or consequences of osteoporosis, obesity and patient's anxiety. All these things sometimes makes both positioning the patient as well as the needle insertion more difficult. Now what is impossible spinal? That is passing the needle into the subarachnoid space is occasionally impossible even for confident, able and experienced anesthesiologists. It is mostly seen in patients with ankylosing spondylitis, calcification of interspinous ligament and ligamentum flavum. This is the position most of the time you come across and you see such patients in the OT. These patients come to us commonly for hip lower limb fractures, urological procedures, arthroscopies. Before going to the detail of how to deal with such patients, let me share with you first experience way back in 2006. I received a call from a colleague and they said that two of us has tried the things for last 2 hours and not getting it. Can you come and help? When I went to the theatre, I examined the patient. He was 80 years old male for re-TURP. He was known case of ankylosing spondylitis and having hypertension, diabetes and IIT for last 10 years. Spinal history was more interesting. He was operated for femur 25 years back. That time also spinal was tried but not able to get the CSF, GA was given. 20 years back he underwent TURP, for same thing got repeated, and 16 years back he underwent IT operation. That time also spinal was tried and there was no access to the CSF. This was the situation in the OT when I examined the patient. More interesting was patient's wording. He told me that पाठीचे पाणी मिळत नाही, तुम्ही मला पूर्ण भूलताय. That was his wordings. So he got used to it so many times. He himself was knowing what exactly is the problem. That time I tried Taylor's approach once. Already patient was impatient and we decided to stop. Even Taylor's approach I could not get the CSF. We decided to postpone, advise the X-ray lower lumbar spine and reschedule next day, making the plan of reattempt or SOS-GA. When I went back home, I searched for the references and I came across 3 interesting references. First of all, there is Martinez CR et al. They had done sacral foraminal subarachnoid block. That was an expanded case report. They used this technique in 40 patients ranging age from 34 to 100 years and were successful in 38 patients and faced technical difficulties in 2 cases. Their conclusion was they proposed this technique as an alternative for difficult lumbar or lumbosacral subarachnoid block. And another was a case report. He was 16 years old male patient of ankylosing spondylitis and they performed subarachnoid block through first sacral foramina. These are the another 2 references which are from the pain actually, and there they had performed a transsacral blockade of inferior hypogastric fluxus in a safe, they advised it as a safe technique, and another was sacral fluxus block performed through sacral foramina. And from these 2 studies I got an idea of using CAM, which is easily available in the theatre. So accordingly the plan of action decided was dural puncture through second sacral foramina under CAM. Next day when I saw the X-ray revealed that there was bridging osteophytes over lumbar vertebra and ankylosing of both sacroiliac joints, and that was the reason why even Taylor's approach was not possible. So informed consent was taken, standard protocol of preparation, pre-medication and preloading was followed, difficult airway kept ready. That's how the patient was given position in the theatre, CM was adjusted, and I could perform successfully dural puncture. So far 36 cases had been done in last 6 years. The most interesting is most of these patients they are already attempted by 2 senior anesthesiologists, and few patients were identified beforehand as a difficult and they were referred, and in 6 patients even Taylor's approach was not possible. When we talk about this technique, the problem which we face in this patient basically is back which is stiff like a bamboo with a zero flexibility. There is mild kyphosis at thoracic area with fusion of lumbar vertebrae. When we see the X-ray, this is how the X-ray of these patients, they give us idea. But if you see properly, one fact comes to our mind that in all these situations, sacral foramina remains intact, and dural sac is another fact which we know is dural sac extends up to the S2, and we take advantage of these 2 things. But then when we actually try this technique in the OT, we face 2 practical problems. One is the locating the point of insertion of needle and to decide the depth and direction of the needle. And for this, the solution is CM. If we use CM, it gives us proper guidelines for both the things, point of needle insertion as well as the direction of needle. The procedure is otherwise quite same, make the patient sitting. Proper painting and draping, point of insertion for 2nd or 3rd sacral foramina by CM is chosen. Local infiltration is given. Preferably, it is preferred to use 23 number needle because maneuverability is good. Even after some practice, you can try it with 25 number needle as well. And point of dural puncture, as I said, is distally, that is at the level of S2. This is how the patient sits, and CM is adjusted. If you see the why exactly you require CM, if you see here, you can see the skin injection point and of S2 foramina, which is 1 to 2 centimeter lateral to the foramina, and needle in the S2 foramina. This is how needle looks inside. And the problem is sometimes you try to go more medially in that situation. This is situation where your needle is more this thing. In that situation, what you do is you withdraw it and go anteriorly. And if your needle is too anteriorly, it looks like this in the CM. In that case, you just withdraw it and go more medially. This is how the needle in situ looks, and this is a CM picture. Free flow of CSF. That's how you can inject the drug. The doses are usually 1.5 to 2 cc, sufficient for most of the lower abdominal or bone procedures. Spinal action you get up to T8 to T8. Because of this procedure, even high spinal is it's not, we don't get high spinal, so not worry about that. Duration of surgery, most of the time all the surgeries last maximum up to 2 hours. Maintenance and monitoring is pretty same like other cases which we use. Other modalities, obviously you can, as sir correctly said in the oration lecture also, you can definitely try and use sonography, and this is a recently published study which is there in our IGA by FMC people from Pune, where they had managed this case of ankylosing spondylitis for total hip replacement surgery with the use of ultrasound. In this case, what they did is they got it marked, taking the patient in the ultrasound room, they got it marked, and then in the theatre, according to that marking, they performed this thing. But then again, the sonography is not available in most of the theatres, but then CM is easily available. Some people may say that it is why not to go for GA. This can be a controversial, but in my opinion, like, okay, difficult airway, their school of thought is like difficult airway, so why not to secure it and then go for a GA. But then as it is true that in not all obese patients has got difficult airway, same is like all the patients who are with a problematic back, doesn't mean that they will have difficult airway. Considering the procedure, age, cardiac problems, respiratory problems, and risk-benefit ratio, spinal anesthesia is preferred over GA. Taylor's approach, yes, it is there, lateral lumbosacral approach from L5 to S1 foramina, but then problem is most of the patient, they'll have sacralization of L5 vertebra, annular fibrosis, bony bridges and kyphoscoliotic changes, which again increases the difficulty. Advantage of sacral foraminal approach, no flexion of back is required, less pain as tough ligaments are avoided, high success rate, controlled level of action as point of dural puncture is quite distal, no risk of spinal cord injury. As already said, advantage of C-arm is easy selection of point for needle insertion, control advantage, advancement of the needle in proper direction and easy availability in almost all the operation theatres. Sacral foraminal route under C-arm guidance is a good alternative in a difficult, impossible spinal situation. These are the references which are available. In most of the references people had not used C-arm, but then believe me that if you use C-arm it becomes quite easy. Thank you.
They don't like to have any further goes if you have more than 2 goes. Okay, they would like to go to sleep. Even after spinal anesthetic, they would like to go to sleep. But it is not the case here. But we need to think about the patient, the practicalities, the use of medications. With the general anesthetic, we use minimum 5 to 6 medications. And I could see that with the spinal anesthetic, we just use one local anesthetic and we can achieve the entire surgery done in a safe and sound manner. Thank you for all the 3 speakers to complete the whole session well within time. And we started with a simple spinal anesthetic spread, the factors affecting. Then we saw Dr. Kumar speaking about the various techniques available to do and assess the spine. And Dr. Mahajan completed by managing a difficult spinal to make it how easy. But again, the question I want to ask you, Dr. Mahajan, is,
yes, sir.
How easy is to use a C-arm? Because if you're not used to use a C-arm and doing, unless you're trained in using C-arm and doing X-ray guided...
It appears difficult, but believe me that it is not that difficult at all. Once you adjust it, in one of my slides you must have seen, once you adjust it properly in AP position, it is quite easy to insert the needle standing on one side of the table. And even approaching is quite easy. If you see that this is how you arrange the C-arm, and you don't require much movement of C-arm also. Once it is adjusted, that's enough. Like you don't have to keep moving the C-arm, and you get adequate space to stand also, and at the same time achieve dura puncture laterally.
Hello.
This is how in another picture you can see it's quite easy to insert the needle.
Excellent talk, Hitendra. Even orthopedic surgeons, they use C-arm, so I don't think that would be any difficult for us, I suppose.
Yeah, and another thing is most of the anesthesiologists in the OT, they are used to using C-arm for orthopedic surgeon. Why not to use it for ourselves?
Absolutely. We do all the backside drive, so I think